Hello and welcome to Beyond the Script. Today we're going to be talking about medication side effects. This is part two, and what I want to do is cover a couple of clinical cases. We use the phrase clinical cases in medicine. Essentially, what that means is reviewing the medical histories of a given patient. So I'm going to talk about two patients that we saw in the course of my clinical career who had very interesting presentations with medication side effects. Now, the last talk I went over the overview, I covered definitions and various things and gave you some background information that can be applied. So what I want to do in today's discussion is talk about two patients that I took care of and talk about exactly what happened with them and see if we can apply some of the things that we learned in part one of medication side effects. It's always good to have an application to what you're dealing with medication side effects. So the first patient is someone that had side effects that were considered, you could consider a combination of subclinical and clinical. And after we review his, I'll share exactly why that may be the case. The second patient I'll discuss is one that many of you may have heard of before if you've heard any of my talks or read my book, but I'm going to go into some details in her case that I haven't done before, and she's going to be a situation where we may consider that subclinical. So anyway, without any further ado, let's get into the first case study. I nicknamed this study Jekyll and Hyde. The first patient is a 76-year-old man. He was a retired university professor, and we were following him for a number of years with a number of medical issues. His problem list included the following. He had a condition, a fairly rare condition known as Brugada syndrome. He also had diastolic dysfunction of the left ventricle of the heart. He had hypertension. He had bradycardia, which is a slow heart rate. He had hypercholesterolemia, and he had an implantable defibrillator due to for the treatment of his Brugada syndrome and also his bradycardia. This defibrillator had some pacing capabilities. He was on medications. He took vitamin B12 supplement, an aspirin, a vitamin D supplement, and he was initially on a medicine called Edarbi and also a medicine called carvedilol. Now, his medication list had changed over the time, but what I'm giving you here is a medication list during the earlier part of the presentation that I will discuss. Now, after he'd been on this medication list for some time, he came to the office for usual management of his hypertension. However, he had reported having nightmares and hallucinations over a period of 3 to 4 weeks prior to this presentation. In fact, one night he says that he woke up, and according to his account and his wife's account, that he started attacking his wife. She had to fight him off. And so we were quite concerned with these side effects because they had a very, very good relationship. And we were concerned about this occurrence. So one of the first things that came to mind is, could it be one of the medications? We decided to decrease the dosage of the carvedilol. He had been on a dose of 6.25 milligrams twice a day. So I decreased that to 3.125 milligrams, half the dose. This is part of the standard dose. In fact, it's the lowest dose. Now, I tend not to like to discontinue beta blockers because sometimes you can get rebound hypertensive responses, and so we try to wean them slowly. So we did a medication wean, followed up with them, and with weaning this medication, reducing the dose rather, he had significant improvement in the symptoms. He only recorded maybe 1 or 2 nightmares a week when he was having them virtually every night. We subsequently stopped the medication and the symptoms completely subsided. So we were quite pleased with this. Now, sometimes when you discontinue a particular medication, you don't always know whether it's the specific medication itself, especially with generic medication that have different carrier molecules. So you may be having a side effect to a cofactor within the drug and not the primary drug itself. So over the course of about 2 years, over 2 years, he had been managed with our situation carefully and is doing pretty well. very well over time, but he was on another medication called nebivolol, and he had been on that medication for several months, and lo and behold, we had increased the dose, and about 2 to 3 weeks after increasing the dose, he came in with, you guessed it, nightmares, hallucinations, and fighting his wife again. So we again weaned him off the nebivolol in a similar fashion that we did with the carvedilol. In fact, I had to review his medical chart because I remember him having these symptoms before, but didn't remember the details and did recall that we had to do the same thing with carvedilol. So again, these symptoms completely subsided after the discontinuation of nebivolol, and we never prescribed any drugs in this class again. So he is officially allergic to beta blockers. Both of these drugs are considered beta blockers. But let's look at these medications in general. Common side effects of carvedilol includes dizziness, unusual tiredness, low blood pressure, diarrhea, high blood sugar, lack of energy or weakness, slow heart rate, weight gain, changes in sex drive or performance, dry eyes, dry itchy skin, headache and nausea, just to name a few. Nebivolol has some similar side effects: dizziness, tiredness, slow heart rate, headache, diarrhea, and nausea. Notice that neither of these have the side effect of attacking your wife at night or hallucination or nightmares. However, if you look at both of these, you have dizziness in both, tiredness, headache is in both. So both of these could have some central nervous system effects. They could affect the brain in some way. And therefore, it's not too much of a stretch to say that these drugs could probably have an effect on the brain, such as behavioral effects. So we tend to think of medications that are psych drugs, psychotropic drugs, that may cause these types of reactions. But medications that are not typically psychotropic drugs can have psychotropic effects. So in this case, you had a psychotropic effect, hallucinations, nightmares, a violent behavior. This has also been reported in other drugs, including statin drugs, which are not psychotropic drugs, but they can have psychotropic side effects. So, we consider this both a clinical and subclinical, because I suspect that he didn't have an immediate reaction to taking these medications. So as a result of this, it built up to some extent and then manifested later. So key points. These adverse reactions are not listed as part of a commonly known side effect. You'll see that a lot in medications. They're nowhere in the list, and patient will complain of certain side effects. And typically I listen to my patients. They'll come in and say, look, doc, as soon as I took this medication, I felt a certain way. When I stopped, these symptoms went away. I'll look at the, drug side effect list and say, well, that's not a common side effect. However, the patient, in this case, yourself or your loved one, knows best. And if you have an adverse reaction, then we have to stop the medication. So, but both of these medications can cause dizziness and tiredness, as we talked about. So as we said before, they can affect the brain. These reactions are not do not occur immediately after. They were a little bit between subclinical and clinical, in my opinion, because even though they didn't occur immediately after, there was a little bit of a delay. There were manifest symptoms that were very temporally related, and the symptoms then went away shortly after. So there's really a subclinical and clinical component, and I think the subclinical part was some buildup in the drug level that has some effect on the brain, and then it manifested, within a matter of months, weeks to months perhaps, in a clinical manifestation. They were in the same class, so it wasn't really anything peculiar about the nebivolol or carvedilol, but the fact that they were both beta blockers, and so he's likely to have an adverse reaction to beta blockers in general. And lastly, the patient's on a different combination of drugs each time. So sometimes you may think, well, if he's on a beta blocker plus a calcium channel block, he will always have this reaction. But he wasn't. He was on the beta blocker with a calcium channel block on one occasion, but then a beta blocker without a calcium channel block on the other. So he had a completely different set of medications. So in this situation, it was a pretty clear-cut incrimination, if you will, of the beta blocker and the class of drugs, since you had two different drug components. Now, the second case, as I mentioned before, is a case some of you may have heard before. This is a patient that I treated very early in my career, and I label this too close to home. Now, this patient was a 69-year-old who presented with dizziness and forgetfulness. She was diagnosed with a brain tumor because when I saw her with the dizziness and forgetfulness, we got a CT of the brain, and lo and behold, a very large brain tumor was detected. It was noted to be benign because of the location. It was a meningioma, and so she needed it to have it resected. There was some associated brain swelling, and the neurosurgeon said it'd be best to take it out before it caused other problems. So, given her medical history, she needed a cardiac workup. We saw her, she had diabetes, history of angina, hypertension. She was overweight and had a history of carpal tunnel syndrome, which was treated surgically. So she underwent an evaluation, and she was found to have significant coronary disease. She was on a number of medications and had her diabetes under good control, as well as the cholesterol. She was taking medication for constipation, but a stress test and the coronary angiogram showed significant coronary artery disease, and she underwent an angioplasty and stent placement, which needed to be done prior to surgery. She waited for about a few months to undergo surgery. She underwent the resection of the meningioma, and it was successfully removed, and we were all excited. However, there was more to this story. We thought we were out of the woods. However, she developed some complication with taking the medications initially. We had to make adjustments in the medication. Also, she developed meningitis, which essentially led to hydrocephalus, which was brain swelling. We tried to treat that medically. However, she needed a brain shunt, which resulted in bleeding. She had a subsequent coma. There was seizures with impaired brain function and more seizures. As a result of hospitalization, we made adjustments in the medication. And despite making numerous adjustments in the medication, she had more and more seizures. She at one point had a full recovery, but had a subsequent decline with more seizures. She fell, injured her brain, had a bilateral subdural hematoma, was on a ventilator for a prolonged period of time, was admitted to the acute care hospital, then subsequently a subacute care hospital, until her condition worsened even then. She had systemic infection, had to go back to the acute care hospital. I remember one night she had an amount of fluid built up around the heart. I had to do an emergency pericardiocentesis, which is to drain blood from around the heart. She also had to have an emergency abdominal procedure to drain blood from the abdominal cavity due to what we call as an abdominal compartment syndrome. This was done successfully. However, during the exploration of the abdominal cavity, while there was only mild injury to the intestines due to the compartment syndrome, the liver was found to be significantly sclerosed. With further exploration, the intestines fully recovered. However, the liver remained sclerosed with significant liver fibrosis. So unfortunately, after about a year and 10 months of a long hospital course, this patient died of liver failure. Now, why did she die of liver failure? This is something that perplexed me. I reviewed her medical records and found a number of significant interesting findings that would explain her liver failure. There's the medication exposure, chronic medication exposure, and the standard American diet were the primary things that I assessed. And as I'll get into the details of that in a few minutes. But the most significant characteristic of this patient is that she was my mother. Now, as many of you have heard me say before, I thought this was a very profound, although heartbreaking, a profound finding at the time, because my mother would tell me, son, I'll be your mother till the day I die. And as mothers do, they teach you pretty much everything: how to tell time, how to potty, how to spell. And this time my mother on her deathbed was teaching me one of the most important lessons that I'll ever learn in medicine. And that has to do with medication side effects and how you manage patients or prevent it from that. So to review what went on with her, first of all, we had 10 medications on the list. Now, this list is not the absolute list. Her medication list changed over time, but about half or more of these drugs are medications that she had been on for a long time, and some were added during her hospital course. But if we look at the list of 10, you see Keppra, insulin, heparin, mycostatin rather, Prevacid, Epogen, Dilantin, Cozar, Coreg, and Zocor. All of these medications were used to treat her different medical conditions, and high blood pressure, diabetes, and all of these things were used to manage it. However, they all had different side effects. But the most important thing was that about half of them heavily metabolized by the liver. The Prevacid, Dilantin, Cozar, Coreg, and Zocor, and some of the others were in part metabolized by the liver. So here we had a situation where she was on a number of medications for years, perhaps over decades, that were being metabolized by the liver. She was on the standard American diet, although it was considered the diabetes diet. There were many preservatives and various other colorings and food dyes that were in her food that also had an effect on the liver. So she was followed by a very good gastroenterologist who was perplexed toward the end because he said he had never seen a situation where a patient without a history of liver disease developed fulminant liver failure. And her situation was such that even in the early phase of her illness in the hospital, we did not see any significant elevation of her liver enzymes. And he never saw this in the many years that he had treated her as an outpatient. If we look at her clinical labs, I'll draw your attention to down near the bottom, ALT, AST, alk-phos, bilirubin-tolan, and bilirubin direct. The ammonia level also on one of these dates was very elevated. The P10INR, which is not on this one, was also abnormal. She had a very high lactic acid. This was near the time of her death. And what we see here is that the liver enzymes were very high and the liver was under a lot of stress. And we know that the liver cells are not working very well as she had a very high ammonia level. I didn't know then what I know now in terms of how to treat a patient like this. She would have benefited from a nutritional detox. And we'll talk about that in the third talk that I'll give you. A nutritional detox could have helped reverse this whole process, and detox and medication weaning might have made a difference in her case. Unfortunately, we didn't know that. However, by studying this and understanding what went on with her, I'm now able to manage patients better today than I would have been able to otherwise. So that's why I say my mother taught me the most important lesson, one of the most important lessons I'll ever learn in medicine. And as I go on and manage patients, I'll always remember her for that. So what are some of the key points of this case? About half the medication were metabolized by the liver. Keep in mind if you're on a lot of medication, understand at least how your body is managing these medications. The medications just don't go in your mouth and come out the other end. They go in your mouth, they get broken down, they have a chemical reaction, they interact with your body. Do you have multiple medication being metabolized by the liver? Do you have multiple medication being metabolized by the kidney? If so, are they putting stress on these organs? And so understand what's happening there so that maybe you can work with your doctor and come up with a plan of reducing the dose or eliminating some medications as well. She did not have any history of liver disease. So, there was not a bad liver. Typically, if someone had alcoholic liver disease or liver disease from some other reason, then you would say, well, hey, this, contributed to the liver failure. But here, there was no history of liver disease. So I'm very certain that the medications plus the standard American diet, I don't leave that out because there are a lot of preservatives in the standard American diet. And I'll actually do a talk on that one day and talk about the chemicals in our food. But the liver disease came about as a result of chronic medication consumption. She had waxing and waning neurological changes. Remember, I talked about the seizures and she was having, and the neurologists and neurosurgeons weren't quite sure because they weren't typical seizures. They were sort of absent spells or various other little, neurological, deficits or glades. They call them plaids. They weren't sure what they were. But I think these waxing and waning neurological changes were waxing and waning liver function changes. And so all of this was likely due to progressive liver failure due to the medication. Despite having diabetes, heart disease, and a benign brain tumor, she didn't die from any of these things. She didn't die from the brain surgery. She had angioplasty, and the type of lesion she had was in the LAD. They call it the widow maker. Potentially would have been a widower maker in her. She didn't die from that. So she underwent treatment and management of these conditions very successfully. However, she died of liver failure secondary to medication side effects. So the number one cause of death did not get her. The number two cause of death did not get her, but the number three cause of death did, and that's medication treatments. And so we need to be mindful of this and stay on top of these things. So my final thoughts are the following. We had two case presentations here today. One where a patient had both some subclinical and clinical manifested characteristics to his medication side effects. It was an unusual medication side effect. It would have been easy to just, chalk it up to, hey, you're having anxiety, let me give you an anxiety pill. But no, we didn't. We said, look, you're on medication. It wasn't a huge list, but maybe this could be a side effect of the medication. And so it's always worth trying to decrease the dose, and eventually wean or eliminate a medication if you think it's causing a side effect. However, you have to have a high suspicion of criminality, if you will, for the drug. So have a high suspicion that the medication may be the cause, not that there's some new cause, because oftentimes I see patients get prescribed yet a third or fourth or some additional medication for side effects that may be due to a medication that they're taking. So you may need to consider weaning the medication. The other thought is that chronic underlying health issues. So if you're on a medication for a while, and let's say you've been taking it for 5, 10, 15, 20 years, and you start to notice your doctor says, look, you have some problems with the liver, some problems with the kidney. Think of these medications you've been taking for a long time. If you have any kind of clinical reaction, don't think that it's not the medication you've been taking for a while. So I've tolerated this medication for 20 years. Well, for 20 years, you have not had any clinical manifestations of symptoms, but you may be having underlying organ dysfunction. And so this may be contributing to the symptoms that you're now having, say, 10, 20 years later. So keep in mind that medications can be like a thief in the night. They can slowly eat away at you from the inside out. And then once you start to have side effects, you have to have a high degree of clinical suspicion that it is, in fact, likely a medication and not necessarily a new disease. Polypharmacy, multiple medications, is in of itself a problem list and a disease state that you have to deal with and manage over time. So I hope this was helpful. I hope these two cases gave you some insight into what can happen with taking medications, and I hope it helps solidify some of the baseline information that we had at the beginning. So I look forward to seeing you next time at here at Beyond the Script, and stay well.